So my interest in hepatology started very early on, actually. I was a medical student at Southampton, and I did an intercalated degree in science, and I did some research in the role of this protein called NF-kappa B in hepatic stellate cells, which are the cells in the liver that produce all the scar tissue. And that really got me interested in the liver because of the fact that the liver is such a fundamental organ. It's an orchestrator of a lot of things, and when the liver becomes impaired, the whole body falls to pieces, for want of a better phrase. So I really became inspired by that, and then I did my house jobs on the liver unit at Southampton General. I then started my further training thinking, let me keep an open mind, and when I came back to do another liver job with Steve Ryder in Nottingham and Guru entail, I thought, yeah, I've come home, and from then on it was an obvious choice. There's quite a few actually, and this meeting, there's been some excitement about this meeting. I think if we go through it in order, I think in terms of diagnostics, in terms of measurement of liver scarring, liver fibrosis, I think fibroscan is now very well established, but it's quite exciting to look at MRI and magnetic resonance elastography, but even actually MRI without an actual physical impulse into the liver. There looks to be some clever computer algorithms that you can use to look at the degree of fibrosis. And the beauty of MRI is it allows you to look at the whole liver, and it isn't dependent on the patient's BMI. So from a liver scarring point of view, I think that's very encouraging. There's lots of exciting diagnostics in terms of looking at hepatitis C diagnosis at point of care, one of my main interests. There's lots of exciting innovations in terms of machine perfusion to look at acute and chronic liver failure. And we're going to take part in Birmingham in a trial run by the A-Liver program, which is supported by eJournal and a European 2020 Horizon grant in a trial called DiaLive, where we'll be treating people with acute and chronic liver failure. I've also been involved in the ELAD trials of alcoholic liver disease. So I think it looks optimistic for the future. So I think if we look at it from different fields, the hepatitis C field, there's been incremental improvement. We're starting to see lots of real life data and a lot of data about retreatment as well. It's quite complex, a lot of it, and it's trying to sift through it. That's going to take a little bit of time after the Congress. There's obviously quite a lot of excitement around the fact that obeticholic acid has been licensed for PBC, and I think that's been a focus this conference. Obviously there's a lot of excitement around non-alcoholic fatty liver disease, and I think that will be a major focus over the next few years. It's been good to see finally some natural history data about NAFL being presented. It's always been a bone of contention how many people actually progress with non-alcoholic fatty liver disease. There's some conflicting data coming out, but there is some data. And one thing that I wanted to get at, but I don't think is clear yet, is whether or not the story of increasing liver cancer after treatment of Hep C with DAAs is or isn't true. And I still think, I suspect we won't really know the answer to that for another 2 to 3 years. Okay, that's a very good question, and one that's relatively easy to answer. I think we have traditionally, as a community, put lots of barriers in the way of treating people with hepatitis C. That's partly because the treatments in the old days with interferon binding were so difficult to give. But we've asked a lot of our patients, especially because some of them aren't particularly very good at accessing healthcare, come from disadvantaged and underprivileged backgrounds, and some of them have very rough lives. So in the past we've said, you've got to have a fixed abode, you've got to stop drinking, you've got to do this, you've got to do that. And I think one of the biggest barriers is actually physically getting them into the hospital in the first place, and actually assuring them that you want to treat them as a human being, and that initial engagement. It's much easier to have that initial engagement out in the community. Okay? And in fact, I think with modern DAA therapies and how easy it is, number one, there is no one I think we can't treat. And number two, and I think most importantly, actually going out there ensures that there's no need to deliver treatment in hospitals anymore. You can take a fibroscan out, you can do your blood tests out and bring them back. Eventually we'll have drug regimens where you won't even need to genotype someone, and then you can really deliver the care in shorter and hopefully shorter periods of time. So So my duties mainly entail organising the meetings of the British Viral Hepatitis Group, responding to consultations and things like NICE, being the voice of viral hepatitis on the British Association of Study Liver Disease Executive Committee. But I think we need to do a bit more in terms of being advocates for treatment of viral hepatitis, advocates for the viral hepatitis elimination strategy. The WHO has launched again here at eJournal. I thought that was an excellent presentation, and really to look at the United Kingdom as a whole and get a bit of an overview and look at where the barriers are and look and see whether as a professional voice we can help reduce some of the barriers towards elimination. I think it's always useful to look at the practice in other countries. I think different healthcare systems provide different advantages and disadvantages. I think generally in the UK we have a good hepatological coverage. We need to improve, it's still not there, but the fact that we are the second most represented country at the ILC 2017 is quite encouraging. I think initiatives like Liver Quests, which my colleague James Ferguson in Birmingham is spearheading to try and improve liver services and quality and assure liver services around the UK will be important. I think something that our European colleagues do much better probably than we do, although I think is we're improving, is collaborating between centres. And I think having been consortia like the EF Cliff Consortium, which in fact Birmingham is part of, is very important, and we could do more of that in the UK. I do, and I think the problem is there's always an underlying tension between service and actually developing services. And I think if I take a UK perspective, in the modern NHS, we're being asked to do more and more and more clinical practice and account for our time more and more. And I think the danger of that is that people will be less able to contribute to professional societies. And it's a shame, because actually the best innovations happen when professionals get together, have time to think, have time to plan, and have time to then implement. Liver transplantation is a great field, it's a very rewarding field, and I think once you've seen one or two patients who were on death's door walk into your clinic room a few months later, you become a transformed person, and you can't help but think that medicine is amazing. And I think actually probably the person who epitomised this most was a guy called Tom Starzl, who was a surgeon who first did the first liver transplant and passed away only in March this year at the age of almost 91. I'm actually reading his autobiography as we speak, and what you realise going through is how much these guys, these pioneers, really struggled to get liver transplantation up and running. People like Tom Starzl, people like Roy Kahn in Cambridge. But actually the reason that they were so driven was because they saw these patients dying all the time. And transplantation has the ability to really turn people's lives around. What we do need to do, however, is increase the numbers of people accessing transplant. We need to increase the supply of liver organs, and that's why I'm a real passionate advocate for live-related liver transplantation. Although it doesn't work very well in the West, we can make it work if there's enough will. And I'm also a great passionate believer in improving the quality of grafts and also looking at marginal grafts and whether they can be used. And one of the things that came out of the ILC this year was the fact that Hep C positive grafts are being increasingly utilised, but in the US, for example, they're only using 15%, and I'm sure they can use more. So celiac hepatitis is a fascinating condition. It's one we see usually on a diurnal, not diurnal, but sort of on a predictable level around February, March, April time. No one knows what causes it. I suspect there's not one condition, it's a bucket of conditions that all present the same way. The issue is it's still rare, and what it needs is a collaboration across lots of centres to be able to do it. It's something that I started off wanting to do when I first started as a consultant 5 years ago, and I haven't had the time, so I'm hoping I can find someone to take that baton on, and maybe actually a European-wide consortium to look at actual causality would be great. My proudest achievement today is actually starting the first outreach clinic for hepatitis C in Birmingham, which is now going to be moving into the main drug use service, and hopefully, fingers crossed, in the next couple of months, starting the first in-reach clinic into prisons in Winson Green. That's from a hepatitis C point of view. One of my proudest research achievements was getting a paper in Science about ACC and pathogenesis of ACC. But actually, on a more personal level, being the father of 3 kids is always rewarding.